floor.
I have some, ma'am. Fakeisreal.org. Please spread the word. Fakeisreal.org. We're going to save lives. Yesterday, we unveiled our Fake is Real, or the day before, our program, which is a multimedia program. We're going to use billboards, websites, emails, Instagram, Facebook to get the word out. And one of the things that we're trying to do with the Fake is Real advertising program is to spread the word that with fentanyl isn't necessarily causing deaths by overdose. It's causing deaths by poisonings. A lot of these deaths aren't necessarily ODs, they're poisonings. And we would have had our Kudu Creative folks here with us tonight to give you a better sense of the program, but we gave them too short notice and there were some childcare issues, but we'll have Kudu Creative here in front of you very soon so that they can go out through the whole campaign with you so that you can see how they're targeting this 13 to 35 demographic, because we're trying to get to the young people with education as quickly as we possibly can, so that we can avoid unnecessary deaths from fentanyl. And that's really what we're after here, and we're going to do that. And too many people are dying, and it takes so little fentanyl to kill you. I think Sue was talking about it the other day. The head of your pencil, that's enough fentanyl to kill you. So if you think of that, that tip, that's enough fentanyl to kill you. So if your weed, which weed is even being adulterated by fentanyl now, any of your pills, your club drugs, something called Molly, I don't know what that is, but apparently it's a club drug.
I was like, I could explain.
What? Oh. Oh, okay, but
But not, yeah.
well, I don't. I know it's some kind of drug, and it's just a little bit of fentanyl can kill you. So that's what
So is it-
fakeisreal.org.
So is it if you ingest it or if it,
My understanding is some people, look, and individual susceptibility, it's a biological concept. Like I might be able to take more fentanyl than you, but some people can die just from contact with their skin. Yeah. There's enough fentanyl. There's been enough fentanyl interdicted at the border in 2022 by the DEA to kill every American. So we're working it.
Courtesy of.
awesome.
But I would entertain a question even if it's courtesy of the floor.
Well, you know, I could make that call, but go ahead, Mr. Heckler.
Just based on this, because I saw, well, first of all, on your point, yeah, I agree this fentanyl thing is out of control. And I'm sorry. Thank you, Linda. It's out of control. I think the case that'll probably be hitting our court is the house on Stefco Boulevard in Bethlehem where the child died a year or so ago or 2 years ago or in the summer, and they found the parents up in New York and they said it was fentanyl contact that did it. So, I mean, you're right. I just was questioning. I saw that the DA is involved with you. Are these like a couple grants? Did we get a grant and he got money, or how?
So these are proceeds from the lawsuits. And he has agreed to give drug and alcohol the proceeds from his lawsuit in order to do these things.
The DA?
Yes, and we're very grateful to him for that.
Okay. So there were no other grants or anything for, I'm just curious if there was any fentanyl grants in the portfolio.
No.
All right.
The DDAP has some money, but we haven't used any of that for this.
All right, thank you.
Okay?
Yep.
Thank you.
What percentage of our opiate money is being used for this program?
Small percentage. Do you,
Give me a minute and I'll give you the math when I,
That's
Get up
fine.
there, if that's
The other
Yep.
thing is, my understanding is there's more coming our way.
over the next 18 years, yes.
Well, I heard a little more recently than that, so have you heard anything that's coming
No.
more recently?
No.
Jesus.
Because apparently more lawsuits were settled. Thank you.
Okay.
First, we'll start with, and I know this looks ambitious, but I think a few of them are just updates and that we can go into the future, but I just thought we could hit some touch. So do you want to do Graysdale first, or do we want to hit some updates quickly? Graysdale, come on up.
So while Stephen's handing out the report, as Stephen hands out the report, I just wanted to give you an update on our star rating. So last month, we had gotten up to the 3 stars. We did lose a star in quality measures, and I can explain that. So what that does is they reevaluated the star rating on one of the quality measures for going back to the hospital, a readmission into the hospital within 30 days of coming out of the hospital. So the time period that they looked at was the end of 2019. They froze it through COVID, and then it's the first quarter of 2022. So they are not looking at current numbers, they're looking at 2 years ago numbers. So during that time and during the pandemic, we had hospital admissions and going back into the hospital. COVID was a thing. It was a plan that Dawn and I had identified when we both took over in 2019, and we were starting to work on it, how to fix it. And then COVID hit, and then we started this a couple of months ago. We started reevaluating how we do admissions from a hospital of our residents coming back and putting protocols into place. A lot of it has to do with documentation and re-education on staff, how to document, how to talk to the families, because it's not Graysdale that makes the decision to send somebody to the hospital. It is always the families and it is the doctors who make those decisions. So we've been re-educating and working with our doctors on what they should expect, because a lot of times it happens on the 3 to 11 shift, and you have maybe covering doctors who aren't specifically at Graysdale. So we're teaching our staff how to have maybe a better protocol on what they need to say to the doctors about the resident. And then we're teaching our nurses how to talk to the families and say, you know, these are things that we could treat here. Your mom doesn't necessarily have to go out to the hospital for an IV hydration. We can do that at Graysdale. So those are things that we started to work on. We also are in with a cohort of other nursing homes and the state to work on getting these protocols out there, so they are going to be across the board with all nursing homes throughout the state. So they started with the hospitals with this readmission, and now they're working with the nursing homes on this. So it's something that we have in place. April is the next star rating changes, which we should see the PBJ change finally. And then hopefully with the new documentation and all the protocols we have in place, we're going to start to see difference in the measures again.
Any questions regarding that? Yes.
There's no PBD average on the paper. Do you have that information?
Oh, I apologize. That was, for December, it was 3.30.
All right, any questions regarding this month's report? You have 25 folks on the waiting list. That's that's beyond the 18 admissions?
Correct. So we always have to do with cautions, do those residents meet the open beds that we have? We look at staffing because we want to make sure, because a lot of admissions come after hours, they don't send them during day shift, they come on the 3 to 11 shift. Do we have enough staff to do? Because you need RNs to do the hospital returns or hospital admissions. So we did what was an interesting, so I do have Graysdale totals for all of 2022. So we had 3,894 referrals from all the hospitals and home and other nursing homes. So that was up from previous years. So we do have the referral sources.
So could you I guess, clarify what constitutes a referral?
Sure.
Is that just a call and request for info? Is it deeper
Nope,
than?
that is actually, so the referrals start with the paperwork coming from the actual hospitals. And we have obviously about 20 different ways that we get referral sources from and admissions documents where they come from. So what we do is then we research the medical records. We look at them. We see, can we meet their needs? Are there behavior challenges? Are there drug issues? Because a new standard in nursing home care is that if you take somebody in with a drug problem, that is your issue to deal with. You have to figure out how to give them the care they need while dealing with the drug addictions. So we have to look at all of those. We have to look at our payment sources. You know, we have to look back, was there anything happening in the last 5 years? Did they gift money? So those are the initial referrals that we get from the hospitals. And then what we do is go through them, then we tell the hospitals or doctors' offices or families or other nursing homes, can we meet the needs of those residents? Or why not? You know, sometimes we'll tell like another SNF, another nursing home, you know, you would start the application for MA and then we'll look at it because we want to make sure you're just not passing, maybe you saw a problem and we're not going to get it and not get paid.
Regarding the hospice house, is that also an individual family decision, or is that a medical decision?
Hospice could be that, a lot of times that happens when there's imminent. So maybe if somebody's passing in within 5 days is usually when they would take them into a hospice house. They want the family to be there 24/7, and not that we can't do that, but sometimes it's a little challenging when you have 4 people in a room. So sometimes we save private rooms, but if we don't have one available, and the resident may not want to move off the floor, but the family makes that decision. So.
And can you say a little bit more about the short-term rehab?
So the short-term rehab is not open yet. We are just now, everything has been painted. We're getting the new curtains for the beds. We put up the blankets, they're cleaning the floors. Therapy's putting all their equipment in there. We have Tower 10 open, so while we have Tower 10 open, we're just watching our staffing because we'd like to kind of parlay that staff on Tower 10 over to Southwest, have them in the other areas while we post our jobs for Southwest 1. So it's a staffing mechanism that we're looking at.
How many beds are you hoping to open with?
31.
31?
Yep, so it'll be more than what the 27 we had on the Southeast 1 unit.
Any other questions from anyone?
I'm
I
sorry.
have a question.
Yes, sir.
My question is, how much time is it when someone leaves and goes to the hospital and then they get returned? How much time is it taking for them to get to the rooms now?
So when they come back from like a hospital return,
Correct.
usually the ambulance just takes them right to the units.
If they're in a wheelchair, how long does it take to get from downstairs upstairs?
Usually Nazareth goes up and gets them. So they usually take them right down.
But that's not our only mode of returning people, correct?
I can't hear him.
I'm sorry, Carrie, could you repeat that, please?
That's not the only company that returns people from hospital?
It seems that the majority now, if somebody was to come in from another facility, Nazareth has been doing mostly, I would say 99%. I haven't seen another company come in a while. But when they do, they would come to the front desk and we would give them directions on where to go onto the units. And they would be met by the floor.
Okay.
Any other questions?
Thank you. I just wondered, and I just want to get up to date, the amount of money a resident can have in their account they're allowed to keep, what's that at now?
It varies. So there's 3 different tiers. It goes from $2,000 to $8,000 that they can have. It depends on the assets that they have on the outside.
Oh,
What?
Yeah, so you can have 2,000 if So it all depends. And Bradford County, which is our MA division, they work through that and they do the calculations on what the assets are. It all depends on assets.
So it's a percentage of whatever your assets are when you go in?
Well, it's what's left. So somebody could have 2 or they could have up to 8.
Well, all right, oh, I see. So in other words, let's say I'm going in and I have $12,000. I don't have a spouse, I can keep 8.
There's a possibility, and they would say that 4,000 would go to the private pay, you'd spend it down at the nursing home, correct?
Well, and also the law still hasn't changed in terms of if someone goes in and their spouse is still living at home, no action is taken regarding assets or home.
Correct.
Joint assets or home until the person that's living there would leave for some reason or something.
Right, so what they would do is, so if you have a home, the home is the spouse can live in it, because they don't want to force the spouse out. But they would look at the assets, if there's cash, if there's retirement in both names, they look at and divide it in half. Then they would say to the spouse, you could use X amount of dollars to pay for their care. Once that gets spent down, then MA kicks in, Medicaid.
Yeah, okay, thanks. I still have people who'll come up to me over the years and ask
that's-
me, and I try to refer them to you, but I realize most of the time they're not calling, so I try to do the best I can, informing them that I'm not the expert here, but,
And we do. We
right.
get a lot of
Thank
phone
you.
calls from the community. And I always tell everybody, we are part of the county. So even though if you're not coming here, and it's a scary situation, having to think, I have to put my wife or I have to put my husband, and maybe the kids live in other states, all they have to do is call us and we'll walk them through. They don't have to say, oh, we're coming to Graysdale. They can go anywhere, but we're here to help as part of the county.
I think one of the biggest fears I get yet is people think if a spouse goes in, or let's say you have a brother and a sister, or two sisters living together for years, if they go in, the government's going to come and take the house out from under me.
Yep.
And I try to assure them that that's not the way it works. And, if somebody suggests that to them, I tell them they should call someone like Mr. Spadoni, but,
Well, and that's it. We always say, there's plenty of elder attorneys in the Northampton vicinity. Just if you would feel more comfortable, just have a consultation.
yeah, you're right. Thank you.
You're welcome.
That answered my question.
Mr. Cusick?
Thank you. I was just checking on the county website. I see we're continuing to advertise for various positions. Can you update us? Is our bonus offer enticing? Any feedback there?
It is. We actually just had about 6 employees return to us over this last month because that is one of the things that they heard. Graysdale has always been their family. They went out to other nursing homes and have decided to come back. And one of the interesting parts was this bonus that is being, besides the sweatshirt.
Do you want to speak about the switch?
Okay. I looked at, specifically, if you could address these, infection control, vacancy there. Is that something that is a concern?
No, we do have an RN in place now who oversees it. We have an LPN in position, and I have a secretary in that office. So it is the vacant RN position that's in there. So we do have staff in there. We would just like it because of the infectious control and how Department of Health and CMS are really concentrating on that. We have that position in there.
I thought it seemed pretty important.
Yes.
There's the other two, the RNAC and the staff development LPN.
Mm-hmm.
Are those critical needs? What's the
We just hired one LPN in a position, and he's actually going to get his RN. So this is another LPN position that we're hoping to fill so that they can oversee those aid positions. So it's promising. People are applying. And then the RNAC position is always because they are the financial people. They're making sure that our documentation is correct so that once an MDS is submitted, that's how we get paid. So they are critical, but I have a full team in there, and this is just another member that we're bringing on.
You mentioned the LPN looking to get an RN. Are they taking advantage of the program that
Yes,
we
they are.
created? Okay, that's good to hear. And then, since I'm on a staffing kick here, I know as part of the COVID relief money, we allocated a significant amount of money, but we withheld some for agency. Are you still able to do without those additional funds that we withheld as far as agency, and what's our agency usage looking like?
Agency usage is high. We still are obviously trying to get our own staff in there. We've had great results with the aides. We had 12 students just in January. We have a full complement of 15 or 17 that are going through right now that we just have and those would be our aides. Again, once they go through and graduate, we offer them positions, but sometimes because we're one of the only ones left that offer this program of training, they may go somewhere else. So it's a balancing act of how many we can keep and retain. But it is, I believe, and what I'm seeing is good, and they're going to the floors and they are becoming our staff members. So that's a positive.
Yeah, so I mean, I guess my concern then is if you're looking to add additional beds and we're still in this quagmire of agency, are you able to balance that financially?
Yes, we've been at some points hitting 3.8, just with, it is a balancing act, and that's what we're trying to do right now. And that's why I didn't rush to open Southwest 1. We're kind of taking a look at the expectation to open Tower 10. As much as we were hopeful that we would not have to open it and we had everything in place, it was a great idea to open it, just to keep, and it's flu and COVID. You know, we've seen flu and COVID come through our building. So that is what's currently on Tower 10 right now.
Any other updates as far as the relief money at the daycare or?
So with the daycare, I just got the letter from Department of Health that they approved their piece of it. So that piece then goes to life safety. I just had to give some updated documentation, architect drawings and renderings to life safety. So he is going through all of that right now. So that is the final okay that we need in order to start the construction.
Okay.
So
Is there an anticipated timeline for that?
it's government, so it's,
It's at the speed of committee.
but we have a gentleman down at Life Safety that we're in talks with. So it's not like we're dealing with a whole bunch of people. We have one person that we're dealing with.
Okay, thank you very much.
You're welcome.
Any other questions?
Just real quick, COVID, how are you guys doing out there? Any resident staff? I know we're apparently tearing off, but.
Well, and because the holiday season, we saw an influx of that. Right now, we currently have between COVID and flu 19 residents that are up on Tower 10. Staff members, we just have a handful, but we have a higher COVID vaccine ratio than even what's the national average is. So we've been doing well with our residents in getting the vaccines.
And I would think, given what the feds have been talking about with the variants and the long term, we're probably going to keep up the isolation unit. We're going to continue to keep that in operation.
Correct.
Okay.
And we are very grateful that what we're seeing, though, is people are recovering. And that's the important piece of it. They're going back to their home units. So I am very grateful that we're not seeing what we saw at the beginning of the pandemic.
That's all right.
Okay, is there anything else? Is there anything else that the committee wants to see on the report? Because Jen and I spoke before, and we will talk after. Is there anything that you're missing that you want to see? Okay, thanks.
Thank you.
Update on the LTSLR.
She'll be back.
Robin, are you giving any part of these reports?
Long term.
Term, something. If I remembered, it's the competency house. That's what I
Yeah,
know.
so.
Another pause. Long pause for reflection.
I'm wearing green,
Pause for reflection.
as is Mr. McClure. Not trying to make a point, but I'm making a point. Oh, you're nervous? Well,
Yeah, now all the reports are that Eagles are much better
sorry.
than the Chiefs. That's all the reports now.
They're what?
What's the spread?
We're recording.
Sorry about that.
Now we'll never know.
What the spread is?
Yeah.
I think you'll know by next week, when it matters.
Would you like to go through your, Agenda
I called
items?
for the LTSR, which we still can't remember what it stands for, which you could tell us
I
every
will
time.
tell you, ORLTSR, it
ORL.
is, I'll stick with the L part, long-term structured residence.
What does the L mean?
Long.
No,
Long,
Long-term.
The OR, it's-
LTSLR.
no,
There's an L at the end. No,
ORLTSR.
Oh, okay.
So the L is long, and the O and the R, I think it's outpatient restoration, long-term structured residence.
Human Services.
So where are we at?
So I have some updates. I'm going to just literally run through some bullet points for you. We finally got Charles Dertinger involved at the end of last year, since we don't speak construction, to make sure that things were progressing. So he just had an updated call with Alloy 5. The doors are finally all in. They have 8 left to install. We have seen photos of the ones they have installed. There's some plumbing that has to be done. They have said they will be able to fulfill a February 15th deadline of completion, with an anticipated ribbon cutting around March 1st. And so we'll know by the middle of this month if that really is, if there's been any other problems. But from a program perspective, our folks have worked to develop the policy and protocols for referrals, and they're working with the courts to inform them about that process. And Comar, who's the provider, has hired an assistant director, forensic case manager, and 2 nurses. And they have selected their specific treatment program and curriculum, as well as the risk assessment tool that they will be using. So they're ready to hit the ground running.
So there's no, is there a CO yet?
Not yet.
And so they have to have a CO before they can start the intake process? Or do you have some folks lined up that could be potential first residents?
I'm not entirely sure. I'd have to find that out for you.
I just want,
I don't think it will happen before the CO, but I suspect there's some identification going on behind the scenes.
and what's the capacity again? Is it only 8 folks?
That sounds,
Hopefully.
give or take, that sounds about right.
So do you hope to start with a full 8, or are you going to slowly introduce,
I just want the building to be completed. But I think Comar will have the capacity to have 8 folks. I do suspect that we will be incremental in that, but it wouldn't take long to get them full.
So maybe we could have them back in April if it's moving along, just to give us a little overview of the programming
Okay.
at some point? Because I'm just curious how they select the folks and what the length of stay is going to be. But again, if they're waiting to develop and see what kind of space they have, I can understand that that wouldn't be clarified yet. So you're optimistic, huh?
I'm perpetually optimistic.
Should we move on? Any other questions? Move on to the bias program?
So you're talking about the bias program that DHS has been working on with employees, just to clarify?
I was talking, no, actually, I was talking about the New Zealand person
Oh,
and our
Yes.
training and our
Gotcha.
children and youth program.
Well, I can give you a brief
But you
update.
could now say both, since I didn't know
Okay.
there was.
I can give you a brief update. We have a meeting on the books next week to train the supervisor in the screening unit on the tool. He's already seen it, but he'll get the full training with his supervisor, who's a program director, and Maria Torres and I. So we are putting the final touches on business practices, and with any luck, we will be rolling that out in a pilot phase with the supervisor next week.
Nice.
Yes.
Does anybody have any questions about that?
Well, I can tell you about the other
Sure.
DEI work we're doing. So we're still working with Intersect Alliance, Guillermo Lopez and his folks. And so all of our DHS staff that were hired as of the fall of last year have had training on diversity, equity, and inclusion, and specifically implicit bias training. And it will be a requirement for all staff to have some form of DEI training every year on an ongoing basis. We're looking at lunch and learns for that on a monthly basis.
Can I stop you for a
sure.
minute? When you say all staff, who are you referring to? All human services?
DHS staff, yes. Yep. Everybody from the clerical, fiscal, caseworker, supervisors. And we've finished some specific leadership training with most of the administrators, and we're down to the supervisors on getting those folks through. And our task force continues to meet regularly to work on these lunch and learn kind of things. So that's where we're going to be rolling out next.
How much time does that program take?
The training, so the first set of training that most DHS staff had was through CACLV, and that was 4 two-hour sessions on different days over about a month. It was about one a week. The current way we do it, it's 1 3-hour training. And then when we have specific issues that arise in the workplace that are not HR related but could use some training, we can have individual work done with folks as well, and it's been really beneficial. And I guess I have to add, we also have I've gotten very positive feedback from children and youth in particular, which is where we see most of our new hires, that our staff and our staff who are folks of color, they are perceiving more support and a good work environment, and they seem to appreciate the culture and the expectation that this is just what we're going to be doing.
Any other questions?
I have a question. Sue, just because we're talking about training for staff and this, do we have any kind of training? Because at one point I had wanted to do this, but it just never worked out. Where our staff, particularly CYF, but others, they come out of college or they're doing one thing or the other and they get this job. And they have an expectation. And sadly, it isn't always what they thought, that people have open arms and they say, you're here to save us, thank you. Do we offer, and I know there are resources available after the fact, but do we do any training or any prep using a psychologist or something to let staff know in the human services when you have contact to contact with individuals, usually, and particularly in situations that are difficult in their lives, or they're not happy to see you necessarily, to understand how not to let that affect them on a personal level, because as you know, you can get called names and you get called all kinds of things, and I think that when people aren't prepared for that, I mean, that can burn out somebody regardless, but I wonder, do we do that, or do we consider doing that possibly? I've always thought that was something that more and more human service, direct service staff should have something like that going on for them.
So CYF staff still, that training has evolved. They still have to do I think it's 160 hours. It's called Foundations, the course. I believe it changed names, but I'm pretty sure that's the current one. So there's all sorts of modules. So some of that is covered, not necessarily with a psychologist, but was it the year of COVID, the Lakeside training? 2019 or 2020,
Yeah.
Robin and 4 of her colleagues in Human Services did how many hours, 170? It was a lot. It was a trauma train the trainer course. And so they have developed curriculum, so all staff, in addition to the DEI work, have to have a trauma training, at least one every year. So not the one and done. And so some of that's being developed now is vicarious trauma, which I think speaks to some of what you are talking about. So, so that's what we're doing right now.
Okay, yeah, I think it's learning and understanding your own reactions when somebody comes at you, in the sense of when you're out in the field. And in your mind, you're doing one thing, and usually these are young people.
Sure.
This may be the first time somebody's actually said to them, you're this or you're that, or and I think it's something, it's like a lot of things. It's something that I've talked about in the past with officials, and it's floated around. But it's one more thing I'll add to the list. We have one of our own now, a commissioner, who is now the director of Human Services in Harrisburg, the new director.
Yes.
So I'll bring this up, as well as my continual pounding on separate classifications for CYF workers. But, so I'll just add that to the list. Thanks, Sue.
Thank you.
Any other questions regarding this? Update on children, youth, and family staffing.
So as you know, when we got here 5 years ago, we've had more folks in seats in CYF. We have more folks today than we did when we got here. We've added new positions, which I have talked about, and I have a blank there. That was a number I forgot to clarify, but it was around 40. And it might be more, so I will confirm that. Our vacancies from the last time I reported are down to 30, with one additional staff starting in the next week, which that would take us down to 29. So we've been able to fill a lot of positions, and I don't like to say it out loud, so knock on wood, we've not had, there's been no significant resignations in the last few months at all. And our CPS unit, which was talked about here as having very short staffing, is down to 3 vacancies. So we've really focused on making sure that those positions are full. So that's going well. And the upcoming recruitment activities include a career fair at Bangor High School, the NAC job fair, and then presentations at Cedar Crest College and East Stroudsburg.
Sure.
I'm sorry, Human Services, I can't break old habits. I just saw recently that the new governor signed, that was an executive order, I don't know, about high school graduates getting in and getting jobs, and I wonder if that's going to filter down possibly to us.
That question was asked on a call either yesterday or Tuesday that I was on, and the short answer was they're not sure yet how that will trickle down. Now, we already can hire caseworker ones in children and youth with a certain number of college credits, which is why we also focus on NAC. So certain degrees or certain subject areas with credit hours is and I think historically they didn't necessarily focus on that, but we are now.
Yeah, and
having luck.
I don't know enough about it to know how it's specified. I just know one of the first things he did was sign that. And certainly that isn't necessarily what you want to do in certain situations. But I just wondered if sometimes when those things happen at the federal or the state level, especially the state, it can come and impact us. So.
We've had a few case aides, for example, who have started with us, and whether it's after 1 year, 2 years, 5 years, end up having enough coursework or work experience, and they have been promoted to caseworkers. So there is a path in the door to children and youth or human services without a college degree.
I'm not sure how to ask this question, so just bear with my
Okay.
thing. So when folks choose to leave that department, do you do exit interviews, or does HR do exit interviews?
Robin does all of our exit interviews.
So if you're comfortable sharing, what are some of their concerns? Because I know this is not a Northampton County
Sure.
problem. This is a statewide problem. I was out in Harrisburg last week, and it's all we talked about is how to retain these staff,
Sure.
workforce issues, and this is the hardest group, because I think they have one of the hardest jobs. But what are some of the things that they're saying? Is it, like Mr. Heckman alluded to, maybe not a good fit, maybe an expectation of how I'm gonna save the world and realizing that it's harder? Or is it the trauma response, or is it a combination, or is there anything that you could share with us?
Sure. I think the vast majority of folks are related to that children and youth is not for them, for whatever reason. And so one of the things, we're big on data, so our assistant administrator's been collecting data for just about a year or two, maybe a little bit more, on how many, first of all, how many resignations we have per year, but then we've broken it down to how long have those employees been here. So I don't have enough data to report here yet, but eventually we will. And so we're really trying to see how many people leave in the first 6 months, how many people leave in the first 12 months, because you know pretty quickly. And I think the bulk of folks definitely, if they're not going to stay at Children and Youth for a while, they leave within the first 2 years. So that's the bulk of it. And then there's always your typical supervisory styles and things like that. But the bulk of it, that's fair, right?
Are there extra layers of supervision in those first 6 months or 12 months to maybe, I mean, have you
Yes.
identified anything that from a supervisory and a clinical supervisory standpoint could be helpful in retention?
So one of the things, in addition to the direct supervisor, there's a training coordinator in Children and Youth. And so when someone's new and is learning a lot of their training, they can go right to that training coordinator. So it's somebody who's been at Children and Youth for some time and, you know, has that experience. So in addition to being able to go to their supervisor with their everyday questions, they also have that person in particular. And since Maria Torres has been with us now a year and a half or so, which I can't believe, I think her clinical skills have added an additional layer of support to the agency. And I think it's been pretty cool to watch that sort of trickle down from her to our caseworkers.
Was that a potential question, Mr. Myers?
Yeah, what's the starting salary for a caseworker ones?
I don't know that off the top of my head. I'd have to find that out.
Are we compatible with the rest of the counties around us?
I would have to find that out. I don't know what it is off the top of my head, Mr. Myers.
Okay, can we get that back in the next month or so?
Yes? Was that a question?
Yeah, I
He
think
just wanted
he
you to
asked
get
if you
back to
could
him.
get back to him.
Robin will
That's
make a
fine.
note for me.
Any other questions?
Yeah.
Yes, sir.
I'm just looking on the website, caseworker 1 and 2, full-time, 39,525 to 43,572 annually. That's what we're advertising on the,
I would have guessed 41 or 42, but I didn't want to be incorrect.
Is that for a one? I'm sorry.
it says 1 and 2.
Okay.
They're grouped together in the job posting.
And what happens if somebody comes in as a 1 because they don't have the right degree or the right coursework or the right experience? When they finish their 160 hours of foundation training and they successfully complete probation, they're automatically promoted to a caseworker 2, so that gives them a boost as well. So, that's an advantage as well for those folks.
But as you know, and you've pointed out, as many directors have, one of the problems you face is that there's no prohibition from people transferring out, and they take the money with them. So, I mean, you got to pay, look, you've got to pay. We've got to pay the piper, you've got to pay people. But I know what happens then too, and you've seen this in your time, is that people leave and they take their salary with them. Whereas if we had a separate classification, we wouldn't be having.
They leave for a different division of human services?
Yeah, I mean, if you're a CYF worker, such and such, C or D or whatever, you know, and
The step.
now, if they transfer, generally they take, that's the rate they get at the new place. Whereas if there was a separate classification totally for caseworkers, let's say they're up to
Yes.
46,000 and they say, I want to transfer. Well, we'll transfer you to the same step for a regular caseworker, but you might now, you'll take a
Right.
drop to maybe 36. And I know there's people that probably wouldn't want to do that, but I mean, I mean, that's just my take on it as one
Yep.
person.
I understand what you're saying.
But, yeah, no, it's tough. I mean, we tried bonuses. I'm just throwing that in based on Mr. Kusik's looking that up. It's really tough when it comes to pay in that area, the good and the bad.
Yep.
Our neighbor to the east just signed a bill to allow behavioral health workers to have college debt reimbursement for however many years they work in the system. So hopefully he'll put in a call to our new resident in Harrisburg, and maybe the two of them could collaborate on something
Our
like
neighbor
that.
to the east is,
Phil Murphy,
oh, okay, I was going to say.
just passed. Because they sent it to us, and I thought, well, I'm way past that, but some of my younger colleagues can take the benefit of that. So, and I think I mean, I can certainly get a copy of that, to circulate over here. Anything else on children, youth staffing?
Nope, not for me.
And then anything on the civil service update?
Yes, I can read you an email. So our folks got, Georgine, my fabulous assistant, and primarily our CYF fiscal folks got all of their salary information into civil service that they told us not to send for the last 4 years. I will give a special shout out to Jill Clark at Pennsylvania Department of Human Services. She spent countless hours and dedicated time each day and each week just to work on this for us. So I got an email on January 19th when I followed up to say, thank you again, Jill, still following up with your supervisor here to see kind of where we're at. And he replied on the 19th and said, earlier this week, OCYF and OA, the Office of Administration, discussed next steps for Northampton's exit from civil service. Barring any unforeseen issues, we plan to circulate an approval letter soon for the appropriate final review and signatures. We will keep you apprised of the approvals. So I will, if I do not hear from them, I will follow up with them early next week. I've been trying not to be too pushy, but pushy enough.
Been a long time coming. How, is 2, 3 years it's taken?
I think 3. And
COVID notwithstanding, but still.
that probably added a year, but it still was a long process.
So in the spirit of optimism, what would hiring practices then look like if we were not part of that system?
So we have been meeting with HR for many months to work on that, and we will be able to hire, like all of the rest of the county, and post on Indeed, and do different, direct campaigns specific to children and youth and aging. I think one of the biggest things, as silly and simple as it is we will be able to, or HR will be able to follow up with every applicant within 24 hours of them applying for the job. Whereas now with civil service, I think HR told me it's anywhere from 2 to 4 months from the time somebody applies until they can start. It might be a month before we even get a list with their name. So our HR folks here have seen some very positive results in other places with that technique, and I'll call people if I have to do that, so we'll get it done.
Good. So it's great, good news.
Not
Great news, good news.
I was hoping for my Christmas miracle, maybe it'll be my Valentine's gift now. But we're there, now it's just passing a piece of paper between Lord knows how many people.
Sounds good. Any other questions from anyone? Mr. Keiser?
Yeah, I had one. I wanted to double back to the comment we had under courtesy of the floor. As far as the fentanyl issue goes, test strips. I know there was some controversy. Where is that? Is that a federal issue or? Because it seems to me like if somebody could test what they have, I see we're mentioning Narcan. Well, on the front side, if somebody could test what they're taking, then they wouldn't need that on the back side. So can you tell us
Sure.
where that is as far as legislation and distribution?
So they're legal in Pennsylvania. We don't currently have a position on it simply because there's really no data on whether or not folks are using the test strips. So we have anecdotal information that says folks who are using substances purchased, through illegal means are not interested in testing their, whatever the drug is that they're taking. They're, simply looking to get high or reduce pain or whatever the case is. So it's something we're going to continue to look at and try to gather data on to determine if that's something that would be of use or not.
Thank you.
Sure. And Ms. Fargo Hefner, you asked about the money. We'll spend about $100,000 this year on the marketing campaign. Honestly, the amount of work that the folks at Kudu Creative have done already, I sort of feel like they've already earned most of that money, but they've just done an amazing job. So we're going to end up spending about $8,000 a month. And the plan tentatively is certainly to continue that into next year. And we anticipate having the funding for it. But it's of the total $11 million, 13 if you include the DA's money, it's a very small portion. The billboards are up today. Somebody emailed me that they saw a digital billboard on 22 and then the vinyl. And we're going to get a couple more as well, so.
And you haven't heard anything more about how the extra money's gonna be disseminated?
No, we talked about that here at some point. They gave a breakdown of how much we're going to get every year for the next, now 17 years or 16 years. And I think on average, it comes around to $500,000 or $600,000 a year.
Sad. Good news, but sad.
Yep.
Anything else? Do you have anything else as a director to report on?
I
any
do not.
other,
Status quo.
No news is good news, right?
Yes.
Okay. If there's nothing else, we can adjourn.
Thank you.
Thank you.
Oh, Linda, I'll call in later.
Yeah, no reason.